Hi there, my name is Matthew Leonardi. I'm a gynecologic surgeon and sonologist at McMaster University in Hamilton, Canada. I'm honored to be invited today by Drs. Falcone and Co. to this incredible controversies meeting on endometriosis, fibroids, and adenomyosis. Today, I'm going to be speaking with you about the basics of performing transvaginal ultrasound to diagnose endometriosis. This is going to be a very instructional, prescriptive talk. My disclosures are listed here. My contact information, there are many places. One can reach me by email or through various social media platforms, Twitter being the most exciting and engaging of the platforms. I do spend quite a bit of time there and look forward to connecting. So why are we here today? Unfortunately, I can't ask you because of the virtual nature of this talk, but I can guess that you're here to learn. You may be a gynecologist who's keen to learn how to perform ultrasound. You may be a radiologist or a sonographer. You may be a training individual in one of those realms. So yeah, learning how to perform and interpret transvaginal ultrasound is probably the main objective. But what's the real reason behind that? Well, we have recognized gaps in the diagnosis of endometriosis leading to a diagnostic delay for patients. So by learning this technology, we may be able to reduce the diagnostic delay that patients experience, allowing them to get treatments earlier. For the surgeons in the room, we have recognized that because of the challenges in diagnosing endometriosis, surgical surprises are unfortunately something that we experience. And of course, we would like to avoid these surgical surprises, and using imaging will allow us to do that. Secondarily, by avoiding surprises, by planning surgery according to imaging, we can optimize our surgical planning, which can involve planning our operative time, inviting the correct consultants to the operating list, which may include colorectal surgery or urologic surgery. Or if you are a generalist gynecologist, you may want to bring along with you one who has advanced laparoscopic training. For me, one of my guiding principles is that patients really deserve to know why they're experiencing the symptoms that they're experiencing. For a long time, we have believed that a clinical or presumptive diagnosis of endometriosis is acceptable. And in the absence of very good imaging, that is entirely appropriate. But as we're evolving in our imaging, we can be much more refined in how we diagnose individuals, giving them control over their body by telling them what is actually going on. The second guiding principle that I have is, as a surgeon, is that I do not want to be surprised at surgery, much like most of you would not like to be surprised at surgery. And so I can use imaging to prevent surprises from happening. Similarly, and more importantly, patients should not be surprised by what a surgeon tells them when they awake from surgery. The informed consent process should be as comprehensive as possible, as detailed as possible, to allow patients to appropriately understand the risk of the surgery at hand. Often, endometriosis management and diagnosis are clumped together. We may not even think so much about the diagnosis. We may just think immediately, let's put somebody on a hormonal medication or let's immediately book surgery. But they're actually separate entities. Diagnosis as an entity may, in fact, even be therapeutic for a patient, understanding what they have and why they're experiencing what they're experiencing. Secondarily, of course, we want to manage their symptoms or manage the disease to optimize their outcomes. For me, the diagnosis and management are separate entities, but they're tied intrinsically by ultrasound, which can really give us management for both the diagnosis and actually the treatment approach. Today's talk is going to, like I said, be very prescriptive. We're going to first talk about the uterus, how to visualize the uterus, how to understand adenomyosis. Then we're going to talk about the ovaries and endometriomas. We'll talk about the anterior compartment, which generally consists of the bladder and the ureters, the posterior compartment, which consists of many structures, primarily the bowel, the uterosacral ligaments, and the vagina. Then we'll talk about adhesions. This includes ovarian immobility, as well as pouch of Douglas or cul-de-sac obliteration. Here we have a graphic of a basic pelvic ultrasound components, as described by the American Institute of Ultrasound in Medicine. This breakdown of content in the ultrasound is quite similar to that around the world, in Canada, in the UK, in Australia. And so you can see it's quite limited if endometriosis diagnosis is the end goal. The uterus, yes, sure, will give us some clues as to adenomyosis. The ovaries, of course, we can diagnose ovarian endometriomas. And if we look at the pouch of Douglas, we may see fluid or a mass, but in the clinical practice guidelines, the assessment of that cul-de-sac is very limited and very vague, actually. So our capacity to diagnose endometriosis on a basic pelvic ultrasound is very limited. So in with the new, which is the deep endometriosis ultrasound or an advanced pelvic ultrasound or an expert guided ultrasound. The name doesn't matter, but as you can see, the components included are extensive. And in fact, in Australasia, the Australasian Society of Ultrasound and Medicine has adopted this more comprehensive approach to pelvic pain on imaging. Our capacity to diagnose ovarian endometriomas remains, but we also have the capacity to diagnose deep endometriosis, obliteration of the cul-de-sac, ovarian immobility, and this is even advancing even further to be able to diagnose less advanced disease forms. So, out with the old. The International Deep Endometriosis Analysis Group is really the group that has been driving this agenda. And a few years ago, they published a landmark study that allowed us to standardize our approach to ultrasound with respect to how we do it, how we measure lesions, and how we call lesions. This is their dynamic four-step approach that is listed here. On this slide, you're going to find a QR code. This QR code will take you straight to that article. So if you pull out your smartphones and open your camera, simply shine your camera at the QR code and a link will pop up. Click the link, it'll take you straight to the PDF of that article. You don't have to take a picture of it, just simply shine the camera at the code. Now, the publication is wonderful, but it may not be the most efficient in actually performing the ultrasound as it could be. In surgery, one of our special E's is efficiency. We want to be efficient in how we actually do our surgery. That applies to ultrasound as well. So Professor George Contis and I have published this How to Perform an Ultrasound to Diagnose Endometriosis paper in the Australasian Journal of Ultrasound and Medicine. Again, there's a QR code that will take you directly to that article. And we've described a different approach to ultrasound that includes all of the same idea components, just in a different order that makes more sense to how the ultrasound is done. And over the course of this lecture, we'll go through all of these different components, starting with the bowel. Why do we start with the bowel? Because as the probe is just entering the vagina, the lower rectum is just on the other side of the vagina. So as the probe is slowly entering the vagina, we can take advantage, we can be opportunistic and evaluate that lower rectum. We may as well then follow the rectum as far up in the body as we can, evaluating the rectum in its entirety, the rectosigmoid junction, and the sigmoid colon as well. As you can see in the graphic on the left, the bowel, as per idea, is broken down into four components. One is the lower or retroperitoneal rectum that is not visible at laparoscopy. 2 is the upper rectum. 3 is the rectosigmoid junction, and 4 is the sigmoid colon. The graphic on the right demonstrates the necessity to measure each lesion identified in 3 orthogonal planes: length, anterior, posterior diameter, as well as the transverse measurement. We also want to ensure that if the disease is multifocal, we measure the entirety of the bowel involvement from the most cephalad part of the most cephalad lesion to the most caudal part of the most caudal lesion. Second, we want to measure the distance from the most caudal aspect of the lower lesion to the anal verge, which will give us some clue as to which part of the rectum or bowel that the lesion is in, and this has surgical implications. All right, here we have an ultrasound clip, and there's going to be a series of these. Some things I'd like to point out. Right now, the probe is in the vagina, of course, and it is looking at the vagina as the structure that's most adjacent to it. The structure that's just deep to the vagina is the rectovaginal septum, which is depicted by this hyperechoic white line. And again, just deep to that is the lower rectum. We can see our lumen here. We can see our mucosa, and we can see our muscularis layer, which is the hypoechoic darker layer. This is the most important lesion area to identify when evaluating the bowel, because this is where deep endometriosis generally exists. We want to keep our eyes on this black line, the anterior of the black line, and we want to follow that up as high as we can. Now, you must be quite malleable in evaluating the bowel because it is not straight. It is very snake-like. You have to have a light grasp on the ultrasound probe and follow that bowel by being very flexible with your hand movements, keeping the muscularis in view at all times. As you can see here, The probe is moving, keeping that muscularis layer in view. The hand movements are light and flexible. We want to try to keep the uterus out of view as we're evaluating the bowel. So in this clip here, the posterior aspect of the cervix is just in the upper left quadrant of the screen. You can't see the uterus. You can't even really see the cervix. It is kept out of the way. The bowel, of course, is in the posterior compartment behind the uterus. We want to keep the probe as close to it as possible to evaluate it as well as possible. Again, in this case, the probe is in the posterior vaginal fornix, essentially lifting the cervix, lifting the uterus out of the way to allow for a close proximity of the probe to the bowel, seeing that muscularis layer. Here's our first video of an abnormal bowel lesion, along with several other endometriosis deposits. So as we scan through here, we follow this muscularis layer, and ultimately we reach this hypoechoic nodule area, which is attached to the posterior uterine serosa. Just pausing through the clip. We scan past it, and then we return back to it in the midline, just there. If one tries to place the probe in the anterior vaginal fornix, this lesion will be much further from the probe, which is just here, much harder to characterize. So placement of the probe in the posterior vaginal fornix is essential to evaluating for bowel endometriosis, as well as other posterior compartment endometriosis that we'll come to in a bit. Here we again have the ultrasound probe in the posterior vaginal fornix. The uterus is just on the left here. We have a retroflexion of this uterus, and we have a bowel nodule just here. You can see how close the ultrasound probe is to the bowel nodule, giving you that really crisp appearance of it. Of course, bowel nodules are hypoechoic in appearance, and you want to try to evaluate the length of it by looking to see where the muscularis is normal cephalad and caudal to the lesion. In this clip, our probe is in the anterior fornix. You can appreciate that just posterior to the uterus, there is a hypoechoic lesion, but you don't see it as crisp as you did in the last clip because of the distance the probe has to the lesion and also the necessity to look through the uterus. So you can tell that there's something there, but this is not necessarily the best way to evaluate for bowel endometriosis. Moving on to the uterus, where we're going to use the morphologic uterine sonographic assessment statement to guide us in our assessment of adenomyosis. Again, we're going to be efficient in our performance of the ultrasound. So whilst we're looking at the uterus, we're going to use this time to do our sliding sign technique to assess for the obliteration of the cul-de-sac. Here we have on the left a very normal appearing anteverted uterus. The myometrium is very homogeneous. We have a beautifully depicted endometrium and a junctional zone around. On the right, we have the graphics that the morphologic uterine sonographic assessment, the MUSA group, has proposed. So in A, we have asymmetric myometrial thickening. Generally, the posterior myometrium is thicker than the anterior. In B, we have myometriosis. The letters are a bit off, but in this graphic here, in E, we have endometrial buds and lines. In F, we have translesional vascularity, which is generally superimposed over a heterogeneous area with myometrial cysts. We have C here, which are myometrial islands. These are hyperechoic areas within the myometrium. D, we have the very classic fan-shaped echogenic shadowing. And then just below in G and H, we have disruptions or irregularities in the junctional zone. In this clip, we're going to see myometrial cysts in the anterior myometrium and the posterior myometrium, posterior being much more dramatic. There's also some fan-shaped shadowing present in this patient's clip. You can appreciate that very dramatic posterior myometrium and then anterior here as well. In this still, we have small myometrial cysts just at the junctional zone. So there is disruption of that junctional zone in this patient as well. And then in this clip here, we have a very globular uterus, very large in size. We cannot really appreciate an endometrium as we are scanning from side to side. This junctional zone is certainly disrupted in this case, and we can very clearly see the intensity of the fan-shaped echogenic shadowing as we scan through. I will encourage you to use this QR code to take you directly to this article, the Sonographic Classification and Reporting System for Diagnosing Adenomyosis. We now have the sliding sign technique, which is a dynamic ultrasound technique that involves the ultrasound probe and or the hand on the patient's abdomen. You can perform this in multiple ways. The Bowel technique, which is demonstrated in both of these graphics here, can be utilized in combination with the advancing of the ultrasound probe forward and backwards, or on its own. So in the next clip, you're going to see an anteverted uterus, and my hand holding the probe is entirely stationary. My left hand is ballotting the uterus, allowing for the visualization of the sliding of the posterior uterine serosa over the content behind it, which is the bowel. So this is a positive sliding sign. In this clip here, again, the probe hand is stationary and the ballotment technique is trying to demonstrate the sliding sign, which it's not achieving. So this is a negative sliding sign. And in fact, at the level of the uterine torus, you can appreciate that there is a hypoechogenic area, which likely represents endometriosis in that location. Moving on to the adnexa, the ovaries will definitely be commonly involved in endometriosis with ovarian endometriomas, but may also have other masses. And so we prescribe the International Ovarian Tumor Analysis Group's statement on how to characterize ovarian masses. We also want to assess the mobility of the ovaries, and that includes the kissing sign. And finally, we want to assess the fallopian tube pathology, if present. So ovarian endometriomas are probably the most recognizable depiction of endometriosis on ultrasound, what people are most comfortable with. So I won't spend very much time here, but we'll move on to mobility. So here we have a very mobile ovary. In this case, we are utilizing the probe, advancing the probe against the ovary to really push it. And it is sliding around its surroundings in all planes. So this is an entirely mobile ovary. In this clip here, we have an ovarian endometrioma as depicted by a unilocular cystic lesion, low level echogenicity or ground glass appearance, smooth internal walls, and no abnormal Doppler vascularity. There's the ovary, and it's not moving at all in any of the planes around it. Essentially, you want to evaluate the mobility against the pelvic sidewall, the uterus medially, and inferiorly, the uterosacral ligament. Here we have a clip of a very immobile ovary against the uterosacral ligament, uterus, and pelvic sidewall. This ovary does contain a very small endometrioma that is very difficult to see. Again, this probe here is actually in the posterior vaginal fornix, and I'll encourage you to spend a lot of your time when performing endometriosis ultrasound in that space. You can see that you cannot move that ovary off of that. I haven't shown much in the way of surgery depictions, but in this case, I am showing this exact scenario. So we have our uterus, ovary, and our ureter in view here. As we proceed through the video, we can see that that ovary is completely stuck to the uterosacral ligament, which is about to be grasped. The ureter is being pulled into the area of disease. And as we start to mobilize the ureter laterally, we can see that the spill of that small endometrioma is occurring. Understanding ovarian mobility is exquisitely important to a surgeon to ensure that this situation is not encountered as a surprise. A generalist gynecologist will probably not have the skill to perform the ureterolysis necessary in this case. So understanding that ovarian fixation at this site will allow for adequate surgical planning. Here we have the fallopian tubes, which can contain hydrosalpinx or hematosalpinx. The lower left graphic is demonstrating a hydrosalpinx, and the two on the top are hematosalpinges. The anterior compartment is a rare place for endometriosis to exist, but we want to evaluate the bladder and the ureters primarily. If necessary, we can implement transabdominal ultrasound for the kidneys. Some individuals are doing this routinely, and some are doing it only when severe endometriosis is identified in that anterior posterior compartment. I'd like to encourage you to read this article on endometriosis in the urinary tract, which I was very privileged to write in collaboration with Dr. Ko. and recently published, along with several other authors, as you can see. And so this article is, again, very descriptive approach to evaluating the bladder, the ureters, in particular for endometriosis. On the left, this is an IDEA published graphic demonstrating the various layers of the bladder where endometriosis can exist. The bladder base being the most common site for endometriosis, and that's depicted nice and clearly on the right ultrasound series. The figure A is a normal bladder. You want to have a little bit of urine in your bladder to evaluate it, otherwise it's difficult to see the muscularis layer. In figures B, C, and D, we have bladder endometriosis nodules in the bladder base. And based on the size of them, they may extend into the dome or the trigone area. So understanding the location of the bladder nodule to the ureteral orifice is very important. You can do that by visualizing the flow of urine on color Doppler on the ultrasound. So you can measure the distance between that ureteral orifice and the bladder nodule. On ultrasound, you can indeed visualize the ureters. They are tubular structures, they are hypoechoic, and they are dynamic. They, of course, dilate and they constrict, vermiculate, of course. You want to try and follow the ureters up as high as possible in the body, particularly past the uterine artery crossing, as this is generally the site of perimetrial disease that can affect the ureters. In this clip here, we have a nodule of the uterosacral ligament perimetrium that is in fact causing a hydroureter, just there. Again, understanding this preoperatively is essential to managing our patients. All right, so finally we have the posterior compartment, which consists of the rectovaginal septum as a very important space in a surgical sense, but actually this is a very, very rare space for deep endometriosis to exist. There is some misconceptions that exist in diagnosing endometriosis. And one of the biggest misconceptions is that the rectovaginal septum is a place where endometriosis exists. The confusion lies in the former term rectovaginal endometriosis, which is essentially synonymous with posterior compartment endometriosis. Calling endometriosis in this space posterior compartment endometriosis will limit the confusion that can exist by thinking that the disease is actually in that rectovaginal septum or rectovaginal space. Posterior vaginal fornix endometriosis is definitely an entity, and though rare, seen. Uterosacral ligament endometriosis is the most common endometriosis that exists, both from a superficial and deep endometriosis standpoint. The torus uterinus and the pouch of Douglas peritoneum are starred because they were not actually included in the publication that we proposed how to perform ultrasound for endometriosis, but have become glaringly, obviously important structures to us. So here we have a still image of the posterior compartment, and each anatomic site is labeled. With fluid in the pouch, we can appreciate the anatomy much more clearly. We can truly appreciate where the rectovaginal septum begins because the fluid is abutting the lowest aspect of the pouch. We can appreciate the posterior vaginal fornix much more clearly, and here we have our rectum. In this video, we're depicting posterior vaginal fornix endometriosis as per this very thickened area in the vagina compared to the adjacent normal area just here. So here's our nodule. We can also appreciate that there is tethering of our bowel in this case, though no evidence of bowel endometriosis. And finally, with the fluid present in the pouch, we can appreciate irregularities to the peritoneum just overlying that posterior vaginal fornix deep endometriosis. This is superficial endometriosis in nature. The uterosacral ligaments, again, are the most common site of endometriosis, but one of the hardest sites to diagnose. So I've spent considerable time and effort on educating people on how to visualize these, both through lectures and through publications. So of course, we have our surgical depiction on the right here, and on the left, with some fluid in the pelvis, we have the ultrasound depiction of the uterosacral ligament. It is a hyperechoic band-like structure that is just past the vagina. When you are trying to find the uterosacral ligament, it is often easiest to find it whilst the probe is in motion because you can determine its location relative to its surroundings, relative to the pelvic sidewall, which contains vessels, and relative to the midline peritoneum of the pouch, which is a very thin hyperechoic area. You'll see this in the video here. Starting in the middle, the probe was looking at the peritoneum, and we're lateralizing our hand to see the thickening of that white line. As it thickens, this becomes our uterosacral ligament. If you start to see vessels, hypoechoic spaces, you've gone too far. You've gone into the pelvic sidewall. Again, remember, our probe here is in that posterior vaginal fornix. If we're trying to find our uterosacral ligaments with the probe in the anterior vaginal fornix looking through the uterus, I wish you all the luck in the world. It's going to be very difficult to see. The uterosacral ligaments are much easier appreciated in that posterior vaginal fornix. Here is an article that I've written. It's a pictorial guide, lots of pictures, lots of videos that will guide people through visualizing the uterosacral ligaments, both in the normal state and the abnormal state. With fluid in the pelvis, via a technique that we've devised called saline infusion sonopodography, the uterosacral ligaments are generally easier to see, but certainly you can see them without fluid as well. You can see here as we're lateralizing the probe that uterosacral ligament comes into view compared to the midline view, which is simply the very thin peritoneum just there. Here we have a uterosacral ligament deep endometriosis nodule that's depicted by the hypoechoic nodule within that hyperechoic band-like structure. So here's our nodule. This is, of course, in the context of an obliterated pouch, as demonstrated by the negative sliding sign. And there's also an adjacent bowel endometriosis nodule here. I'd like to remind people that the surgical visual of this will limit your ability to understand the nodule in the uterosacral ligament because the adhesion state will not allow you to see deep to it. Tissue is opaque at surgery versus at ultrasound. It is, of course, not opaque. And so ultrasound gives you a very different glimpse to the pelvis than surgery does. Unfortunately, uterosacral ligament endometriosis and torus uterinus endometriosis is very complex. It distorts the anatomy so significantly that it can be quite difficult to understand. And so it takes time to really understand it, and it certainly does take somewhat of a surgical understanding to also understand the disease sites and type. So in these two visuals, you have a nodule that extends from the uterosacral ligament all the way through to the torus, here and here, and in this case, we also have some vaginal endometriosis as well. Now, the peritoneum of the pouch of Douglas is something that was not really incorporated that comprehensively into the IDEA consensus statement, but is something that we are beginning to explore. And I think for some time has confused the entity of rectovaginal septal endometriosis. So here we have the peritoneum and we have nodularity, very small hypoechoic nodularity just within that peritoneum. This video depicts a very small nodule as depicted just here within that peritoneum. If one is trying to imagine where the rectovaginal septum is in this case, well, you can follow your muscularis there, right of screen, and the rectovaginal septum is actually off screen here. How do we know that? This is small bowel that's filling the pouch. So if this nodule is in the space just adjacent to the small bowel, it is not retroperitoneal. A rectovaginal septal endometriosis nodule has to be retroperitoneal, and this is not retroperitoneal. So this is actually just in the peritoneum adjacent to the vagina. Finally, the site-specific tenderness is something that is encouraged to evaluate. It is obviously relatively non-specific because people can have pelvic floor dysfunction, they can have issues with IBS, they can have interstitial cystitis or bladder pain syndrome that will cause tenderness in the vagina on examination. We encourage this to be done at the end of the scan so as to not interrupt the scan if a patient does experience lots of pain. This simply requires probing forward and back in these various areas and asking the patient whether they experience pain there. The last thing I'm going to leave you with is also not included in the IDEA consensus statement, nor is it included in our publication on how to perform ultrasound for endometriosis, but it is where we are heading, trying to visualize all phenotypes of endometriosis, superficial endometriosis being the most common phenotype, of course. These are the spots where we may consider visualizing superficial endometriosis. It is much easier to appreciate when there's fluid in the pelvis, either natural peritoneal fluid or fluid that we iatrogenically introduce through a technique called saline infusion sonopodography. This is a technique that essentially mimics a sonohysterography or a Hycosi test, whereby you're putting an intrauterine catheter with a balloon, infusing fluid through the uterus and the fallopian tubes that will ultimately settle into that pouch. Of course, the tubes must be patent. Of course, obliteration will limit the filling of fluid in that space. So these are entities that you will not get the ability to see superficial endo. But when fluid fills that space, you can evaluate for it. Here we have a video depicting hyperechoic projections that are coming off of the peritoneum in the pouch. Again, in this video here, we have our uterus, we have our vagina, we have the overlying peritoneum, we have bowel here. These nodules, or deposits rather, nodules may not be the appropriate terminology here, are superficial endometriosis. In this video here, we have a very clearly depicted projection off of the peritoneum that's just overlying the back of the vagina, essentially very close in proximity to the cervix. And again, I haven't shown very many surgical depictions in this, but this is the exact surgical depiction of this lesion. This is the article that we have recently published demonstrating that there is diagnostic accuracy that is very optimistic in superficial endometriosis. I encourage you to have a look at this article and understand the various depictions of superficial endometriosis on ultrasound and understanding the technique implemented. And finally, I would just again like to thank the organizers of this incredible meeting. I would like to thank you as the audience for attending and being interested in diagnosing endometriosis. There is a huge need here, and this is something that I'm so passionate about, and I hope that others will become passionate about it as well, to fill the gap that exists for our patients and for ourselves as the clinicians looking after them. I'm always happy to chat either through email or through social media. This is again my Twitter handle. Here's a QR code of a number of articles that I've published on this particular topic. And so if you're keen, please do have a look. And finally, I'd like to encourage you to consider attending the international symposium that ISWOG, which is the International Society of Ultrasound in Obstetrics and Gynecology, is putting on in April of this year. It is, of course, virtual, so anybody can attend from anywhere. There's going to be a huge North American presence, both from gynecologists and radiologists. And so this will span all of gynecology as well as obstetrics topics that you may be interested in. So I highly encourage you to consider that. And again, just another thank you, and do look forward to the Q&A session. Take care.